Hey, good morning, everybody. I'm learning a lot about the Navy. In the Air Force, we have Wi-Fi, but you guys don't have no Wi-Fi on the ship, no elevators, but you have shag rugs and adult coloring books. I'm a fan. I'm Lieutenant Thornton Gallimore, registered perioperative nurse, and I'm joining you from Brooke Army Medical Center, Fort Sam Houston here in San Antonio. It's a pleasure to share our evidence-based practice, or EBP project, regarding pressure injuries that three of my nursing colleagues and I completed at the nurse residency program back in 2023. We selected perioperative pressure injury prevention based on observed inconsistencies in skin assessments, pressure injury prevention methods, and related documentation practices. Furthermore, the absence of departmental guidelines and pressure injury prevention opportunities highlighted curricular care opportunities for enhancing patient safety and quality of care. Initial data from patient safety reports and from our hospital's wound care team identified 6 baseline occurrences of pressure injuries across 2 consecutive quarters. Pressure injuries not only present a risk of harm to patients, but also impose considerable financial burden to our institution. On average, the cost associated with the care of each pressure injury is estimated at $43,000, underscoring the significant economic and clinical implications. The goal of our EBP project was to identify and pilot best practices to reduce perioperative pressure injury prevention occurrences. We utilized the Iowa model and, guided by a literature review and adherence to national guidelines, and crafted a pressure injury prevention bundle pictured here on the right. This bundle is a progression of care concepts which includes several elements: a comprehensive skin assessment, team communication through communicating through attending providers' risks and safe positioning, utilizing the safest and most effective supplies and equipment, applying the appropriate interventions and protective devices such as prophylactic dressings and padding, and lastly, documenting the interventions into the EHR, the electronic health record, and providing an accurate handoff communication. Reported results following the pilot of the PI bundle have been 0 to date for 256 participating cases. Data collection is ongoing as we continue to build on a sustainment process with key stakeholders and leadership involvement. The impact to military nursing leads us to how we can influence and improve our performance as an organization. We can tailor our projects towards being a high reliability organization, including sensitivity to operations, commitment to resilience, and deference to expertise. Lastly, our efforts are in line with DHA's quadruple aim. We can provide better care through building on effective interventions and policy improvement. We can provide better health through fierce patient advocacy and reduce pressure injury occurrence. And we can lower cost by reducing pressure injuries that previously cost $43,000 per patient injury, extrapolated from 6 occurrences over a 6-month time frame. Extrapolated over a year's time could be $500,000 annually savings per facility. And we can increase readiness by providing better, safer care, which results in a healthier force population. Very special thanks to Dr. Richard Anderson, CNS, for helping me along the way. And thank you so much to everybody for fueling and motivating the next generation of nursing leaders. What questions do you have?
Colonel, can you use the microphone so the internet individuals can hear you?
Can't see you though. So Colonel Damiani, I'm the chief nurse at WASC, and one of the unfortunate pieces for a chief nurse, we have to do a lot of PCEs and standard of care stuff, and this has come up multiple times. So one of the things during these processes that there isn't a good, there's good pre-documentation and post-documentation, but the standards are pretty vague, like as far as documentation during a procedure, when it actually happens and how you document it. So as far as, did you come across that or any recommendations during how to do that?
Yes, sir. That's a great question. Documentation, especially as we transitioned over to Genesis from our previous documentation mechanisms, it's been a challenge. We are embracing a perioperative approach to this, and we're taking the same strategy across the perioperative continuum to be able to take pre-op, intra-op, and post-op and synchronize those in the best way we can with the system that we have available. There's still a long way to go with that. We still have a lot of obstacles to overcome with documentation especially, but this was kind of the genesis, no pun intended, of getting that communication going in the right direction. So our handoffs are not reliable right now because of us being hamstrung by Genesis and the way we document intra-op. So it's definitely something we're going to continue to develop and expand on. Great question.
Okay, this was excellent. Is this on? Okay, thank you. Thank you for this. If you were to have, I don't know, an EBP grant or something, or a project with the expeditionary rig, would you be able to do more with your PI prevention bundle in a way to operationalize it for deployment, long transport? Because that is actually a thing that is on the strategic map for combat casualty care, but unfortunately, it's not a super high priority and it doesn't have any money behind it. So I think one of the things that we could do to influence that care, because I'm responsible for that aim specifically with no dollars, is think about ways to take things that are being done inside the MTF and perhaps make it bigger with more data behind it so that we can get that adopted elsewhere. Thoughts?
Yes, ma'am. I think that's a fantastic idea. We certainly could. I think that would be a dramatic increase in interest. We're doing a lot of these things just at the unit level, very grassroots. And I think if we had more funding opportunities, and it would give us a much broader voice and to push that data out, maybe through TSNRP or through one of the rigs, I absolutely think that would gain interest. It would gain buy-in, and it would bring in folks that are skeptical of these. Like some of the folks that have been doing this for years that I've had a lot of those barriers present with, I would have evidence to back that up and interest from all the colleagues to back it up. So absolutely, that would be fantastic.
Well, I'll see you at 1:20.
Sounds like I'm going to that rig.
In the Robert Johnson room. And you just spoke to our funder. So awesome
I'll be
presentation.
seeing you there, it sounds like. Thanks, y'all.